Good afternoon, everybody, or good morning, wherever in the world you may be. I know we've got a lot of people joining us from different parts of Africa, so I'm thinking for most of us it's at least just past midday or in the early afternoon. So welcome to this sSCAN webinar from wherever you're joining us today. You're very welcome. And I'm really pleased to introduce you today this webinar on orofacial clefts in Sub-Saharan Africa, focusing on epidemiology care and prevention. And this is brought to you by the Sub-Saharan Congenital Anomalies Network, together with the Global Health Network organization that's based at the University of Oxford. So please drop us a line in the chat. Let us know where you're joining us from today. We'd love to hear from you. And we're just going to run through a few more slides with some housekeeping and outlining the program before we introduce our first speaker. So just to let you know, in terms of housekeeping, this webinar is being recorded and it will be shared on the sSCAN website or Knowledge Hub. And you can see the website there, scan.tghn.org. And you can also access there not only this webinar, but all the previous webinars that have run since 2021. Going forward in the webinar today, please use the chat function, as I've indicated, to introduce yourself. Also, if you're having any technical issues, our colleague at TGHN is online, Louis, and he will assist you with your technical issue. And I see he's just asked us just to say you will stay muted and your microphone and camera will be disabled. But when we come to the panel discussion at the end and the Q&A, we can undo that so that you'll be able to ask your questions. But we would prefer, if possible, just to post your questions in the Q&A function primarily. And you can post anonymously if you so wish. And we're going to run through the program, but there will be 5 speakers. And then if you can submit your questions as you go along, or just keep them, make a note of them somewhere, so that at the end, all the speakers can come back on screen and on video, and we can have a nice discussion at the end, because I think there's going to be a lot of interesting points that are raised. So when we do that at the end, we'll ask you just to raise your hand, and Louis will enable your microphone so you can ask your question. And we just did want to include a warning. Obviously, we are focusing on orofacial clefts today. And because of the nature of the content, some of the images are going to be quite graphic. So we just wanted to put out that warning. And we just wanted to let you know as well that we do have consent for all the photographs that are being shared today. So today I'd like to introduce myself first of all. My name is Dr. Helen Malherbe. I am a director at Rare Diseases South Africa, which is a non-profit company based in Johannesburg, South Africa. I'm also affiliated to Northwest University, so I have an academic hat and a patient advocacy hat, and I will be chairing the session today. And as you'll have seen, we are bringing it from, this is a sSCAN webinar, and we've run a series of these since the project was begun in 2021. And as you may know, those of you that have joined us previously or had a look at our website, we are a network in Sub-Saharan Africa that came about through some MRC UK funding, some seed funding in 2020 and 2021. And there have been a number of outputs and activities and events already, with our last annual meeting being held in Cape Town last year. And previous to that, there was another annual meeting in Uganda. So we're very excited. If you're new to the Sub-Saharan Africa Congenital Anomalies Network, please do check out our website. If Louis can just drop that into the chat as well, because we've passed that slide, so you can take a look at the website and find out more about our aims and what we're focusing on. Ultimately, it's to improve research capacity and surveillance of congenital anomalies in Sub-Saharan Africa and everything that entails. So please take a look and consider joining up with us. And I'd like to now go onto our program, and we've got a really great array of 5 speakers this afternoon. And I'm going to introduce those individually, but the kind of perspectives that we're going to be focusing on, we're going to be talking from a plastic surgeon perspective, a speech therapy perspective. Then we're going to move on to actually what's happening on the ground in terms of Operation Smile and their speech program in Ghana. And then we're going to have an etiology or epidemiological counselling and prevention approach on syndromic and non-syndromic OFCs. And then we're going to wrap up with some lessons from the orofacial clefts research, talking about the genomics of OFC. So we've got a very wide participation from across the world today. And as you can see from the slide now, we've got, this is in terms of registrations. And I see that we've got almost 80 participants online, but we had huge sign up from Nigeria and Uganda, Kenya and Ghana and South Africa, Ethiopia as well. And I think it's great to see that the majority of countries listed there are from Africa and Sub-Saharan Africa particularly. So it's very exciting to have such a huge contingent that is representative of the SCAN area. So it'll be exciting to see afterwards how many of our actual participants and where they're from. So thanks, Louis, if you could move on. Yes, so I've introduced myself already. I'm based at Rare Diseases South Africa, and I have another foot at Northwest University. And since the organization has got started in terms of SCAN, there's been a core group that have really been working on this and continue to work on this. I see a number of them are on the call, including Emma and Daniel and so on. So thank you very much for joining us and for supporting. Without further ado, I would like to introduce our first speaker. And this is one of those amazing people whose CV is so extensive. It's literally, I don't know quite where to start. So I'm going to give the basics of Professor Mekonen Eshete. And if you feel I've missed anything significant, Prof, please intervene and fill in those gaps. And Prof Eshete is going to be talking on orofacial clefts, burden of disease and care in Sub-Saharan Africa. He is currently working as the director of a multidisciplinary cleft care center at Yekakit 12 Hospital Medical College. He's been there since 2007, where he's not only an associate professor of surgery and a plastic and reconstructive surgeon, he's also a cleft lip and palate program leader, playing a number of roles at these organizations. He's also a leader of Smile Train at his cleft center, and he has served on the African Medical Advisory Council of the East African Wing. He's a member of the Smile Train Research and Innovation Advisory Council. And not only is he a surgeon with specialty certificates in general surgery and a subspecialty certificate in plastic and reconstructive surgery, and has a wide range of experience in general and plastic and reconstructive surgery, but collectively, he's got over 20 years of clinical experience. I mean, these are an example of the amazing resources that we have in the region. He also has a PhD in public health that he completed in May 2018. And he's really sharing his knowledge. He's involved in curriculum development in the training program at Addis Ababa University College of Health Sciences and at Jimma University. And he's also mentoring plastic and reconstructive surgery trainees as well. And he's involved in so many other things. He has a lot of other honors for best papers and recognition by a number of organizations. And he's a member of many organizations, including the American Cleft Palate Craniofacial Association and the Ethiopian Society of Plastic and Reconstructive Surgeons. He's contributed significantly to science. And yeah, I'm going to hand it over to him, and I'm sure he will fill in any gaps. And looking forward to what you're going to share with us, Prof. Thank you. Over to you.
Yeah. Thank you very much for a generous introduction. I'm really grateful. I'm grateful to the organizers for this initiative. I'm sure. Can you hear me?
Yes, we can hear you loud and clear.
Yeah, thank you very much. It was really a pleasure to be part of this. I really appreciate the work you do. I'm sure this will bring a huge change to the management of birth defects in general, and specifically to cleft cases. Thank you very much. So Africa is one of the second populous continents with a population of 1.4 billion. It is increasing very progressively. And most of the countries are in the Sub-Saharan region. Only few countries are in Northern Africa. There is also another division of African countries like Central Africa, Western Africa, Southern Africa, Eastern Africa, and Central Africa. But all these countries, the majority goes into Sub-Saharan Africa. There is an estimated 7.9% of total births worldwide are born with a birth defect. And unfortunately, the majority are in our continent. And the other unfortunate thing is that there is no birth defect registry in most of our countries. And because of this, the number of children born with birth defects is not known, including one of the commonest congenital anomaly, which is orofacial cleft. It is one of the commonest anomaly with an incidence, worldwide incidence of 1 in 700. The prevalence varies from 1 to 2,500 to 1 in 500, depending on the geographic origin, racial and ethnic backgrounds, and socioeconomic status. There are varying reports from Africa. To my knowledge, the biggest report came from Kenya by Khan in 1965. And the list was also reported from Ethiopia. There is also a report from Uganda. But you know, these are, most of these are based on surgical data. And you know, the surgical data includes only those who are operated. It doesn't include the stillbirths. It doesn't include those who are not treated. And as you all know, it's very few are got the chance to get the surgery. And it means the data picked up only very few cases. So there is a huge underassertment of orofacial clefts in our continent. Ideally, the management should start prenatally and continues to adulthood. Well, I'm not really supportive of like prenatal diagnosis and so on, because in multiple negative things are going on, like stigma, curse. So if prenatal diagnosis is going to be the norm here, I'm sure there will be a lot of abortions. There will be a lot of children will be killed because of the myth around clefts. So obviously it requires the involvement of many professionals. It's not only the work of a surgeon, it is a work of multiple professionals. Some of the professionals needed are like psychologists, and surgeons, speech therapists, orthodontists. So these are to be involved. In Sub-Saharan Africa, the management of children with orofacial clefts starts at birth. This is not for all common to start management at birth. And usually it is like an unexpected event because there is no prenatal investigation. It may lead to, may end up in rejecting the child. And there is, as you know, there is still parental acceptance is an issue here. There is a poor parental acceptance. And one study from Ghana, which I found, was the mothers, when they know they have a child with cleft, they feel sad. There is anxiety, and they were worried what will be the fate of the child and what will be their fate in the community. As you know, there is also stigma, which might lead to social isolation and will contribute to poor parental acceptance. And feeding is really a huge challenge here in this part of the world because of the poor parental acceptance, because of the stigma, because this is related to curse, as if something has done some wrong thing and God had cursed them and they gave this child. So they really very difficult to convince mothers in our continent to put into her breast a child who is born with orofacial clefts. We're also lacking supportive feeding devices. It's not available really. And you know, pre-surgical management is also missing in most of our centers. And this leads to like the picture we see with severely protruded premaxilla, which may end up in post-operative complications usually. So this is really another huge problem. There is no also systematic from toe to head physical examination of a neonate or an infant at delivery wards or in the pediatrics room. There is many anomalies are missed, like hypospadia, cleft foots, isolated cleft palate is really commonly missed, and also untimely diagnosis may make the management very difficult, and the outcome will be inferior. So the optimal timing of cleft surgery vary across cleft centers, but most agree that cleft lip should be repaired starting from 3 months onwards. Cleft palate, some centers they say 9 months. Now we operate at 9 months, from 9 months onwards. This is in agreement with management plan proposed by American Cleft Palate Association. So it's agreed that if someone follows this guideline, the child will have a better aesthetic outcome, speech will be better. So that's the teaching now, to stick to this timeline for children born, for the management of children born with clefts. So it is also very common to see untreated or badly treated clefts in our continent. And this affects the function of the face and oral cavity. And also there will be severe psychological trauma for parents and for the child. This may lead to malnutrition, which may affect the time of surgery, and subsequently the outcome will be worse. If a child is not operated like at the age of 1 month, 9 months, or 1 year for his cleft palate, the outcome of speech will be inferior. In fact, there are reports adult cleft palate has a good result of speech, but generally it is not easy to re-educate a child who has got learned in a different way. Malocclusion is very common. So malocclusion, if it is not managed timely, many concentrate on what we see on a cleft lip only. So they don't concentrate on function and what is inside. But later on, when a child started to stand for himself, he will ask for management for what is possible. But based on our capacity, which we can easily manage when the child is really 7 years old, we cannot manage when the child is 16 years old. So this is one really very difficult situation we are facing in most cleft centers. Deficiency of maxillary growth is there. The ear problems are huge, which may lead to deafness. Of course, repeated respiratory infection, which are also really causing a surgery very difficult, and mesh delay is also one huge problem. So in this part of the world, it is very common to see untreated adult with cleft palate, lip and palate. For example, this man to the left, he lived with this anomaly. He has gone all the psychological burden, all the insults from the community, and he thought that he should live with this. But later on, his grandchildren started to be ashamed of him. They asked him to get the treatment. So because of his grandchildren, he came to our unit and we got treated. Because there is no pre-surgical workup, you see, severed the protruded premaxilla. A surgeon attempted to close the lip, but end up in such complication. You also see very frequently badly treated cleft palate. Like in the picture we see, this girl has lost nearly 85% of her palate. Imagine how difficult to reconstruct her palate with the remaining tissue and with the capacity we have. So delaying treatment, treating badly cleft palate can have destructive physical and psychosocial consequences. And infants born with cleft palate can have difficulty breastfeeding, leading to nutritional insufficiency and reduced growth and development. and can suffer from nasal regurgitation, which might lead to lasting pain and discomfort. People left untreated may lack the ability to communicate efficiently. Like the man you see, he is 18 years, he was not operated for his palate. He was operated for his lip because that is visible, but the thing which cannot be easily seen, parents think that this is given less priority. So as I've already discussed, the management of children with this anomaly demands multiple surgeries, multiple interventions. One single surgery have never been enough for a cleft child, especially in our continent. We are skull formers. There will be a lot of deformity which needs revision and to be redone again. And also the materials we are using, the suture materials, if they are not timely removed, they contribute to infection and bad scar. Speech therapy, orthodontic care, ENT, all these are really demanding. You can ask yourself in how many of the cleft centers all these professionals are working together. In a very few, I imagine. So any surgical intervention is a major event for patients and families in our continent. Like cost is really an issue. Cost of travel is really huge. They need to travel long distance because there is no cleft center which provides near to their village or where they live. And when they travel, they leave at home maybe 4 or 5 children, which really complicates the management. There is also fear of travel to a bigger town. Maybe they have different language, we are multilinguistic, and they might go to car crash because they are traveling from distance farmer association. So some years ago, Olasoji et al. Reviewed some of the challenges of cleft care in Africa. They searched published articles from 1965 to 2006, and the findings were they couldn't find reliable incidence data. They found that there is a strong traditional belief system existing regarding etiology of cleft, like it is scarce, many things are associated with it. And they found that cleft is commonly present late, and they found that multidisciplinary care is only provided in few centers. So they concluded that the chance that a child born with a cleft tomorrow in Africa will receive the best care possible cannot be guaranteed. And they need to formulate basic strategies to improve the standard of cleft care in Africa, and the rest of the developing world is overdue. This is their conclusion. This was their conclusion. And when we see now, all of the challenges discussed by them are still existing. There is still a financial constraint. There is a lack of infrastructure which provides comprehensive cleft care closer to the community. In fact, there might be in a few, all are concentrated in the bigger cities. Lack of trained personnel is still there. There is no government cleft care program. In most places, cleft care program is completely dependent on charity organization support. In addition, it is not a priority for the government. There are other health issues. So the way forward, I propose the following. We need to involve the government in each country in their country's cleft program. This would be initiated through identification of stakeholders like Ministry of Health, Ministry of Education, professional societies, etc. And I think charity organizations who are supporting cleft should collaborate among themselves so that strengthens the cleft care. And I think we should initiate step by step to increase the role of government in cleft care. And we should strengthen the existing cleft centers and support the establishment of new cleft care centers. We should bring the service closer to the community, support research, community-based researches, strengthen international collaboration, we should involve the health sector of African Union in cleft care. I think we should also strengthen Pan-African Association of Cleft, Lip, and Palate. We should involve more hospitals and surgeons with appropriate training in cleft care. And I think we should support Sub-Saharan Congenital Anomalies Network because they are doing an excellent work, which really may change, I'm sure it will change the care of children born with congenital anomalies in this part of the world. Thank you very much.
Thank you very much, Professor Eshete, for that really good overview to get the ball rolling here. And yeah, I'm looking forward to coming back to it. We've already got a couple of questions posted in the Q&A, which we're going to deal with in the panel discussion at the end after all the other presentations. So keep those questions coming. And thank you, Professor Eshete, again for a really good overview. I'm going to move on now and introduce our second speaker. And this is somebody who I think would be very interesting to have as a dinner party guest, if I still had people over for dinner, which post-COVID is a less likely thing. So I'm excited to introduce Roslyn Lentin, who is a speech therapist from South Africa. She is going to be speaking on the role of speech therapy in cleft care. She's a registered speech therapist with the HBCSA in South Africa. And she graduated way back in 1978 with a BSc and started with her professional career at Orofacial Hospital in Cape Town in 1980. She's officially retired, I see, Roslyn, in 2020, up to which point she was, for the past 20 years, essentially the assistant director of speech therapy, as well as a part-time lecturer and clinical mentor in the Division of Communication in Science and Disorders at UCT. She's been very focused on providing a very large service delivery component, specializing in adult dysphagia, neonatal feeding difficulties, benign and malignant voice disorders, and post-laryngectomy voice restoration, all key points and of importance in cleft care. She's also been a member of the multidisciplinary team at the Cleft, Lip and Palate Unit at Red Cross War Memorial Children's Hospital in Cape Town for many years. She's authored and co-authored a number of journal articles in this area. And since retiring from Orofacial, she's continued to work, as many healthcare professionals do, to work at the cleft unit and also in private practice. And this is why I think she'd been interesting as a dinner party guest. She's volunteered for Operation Smile and has been on a number of missions to Rwanda, Malawi, and Ghana. And more recently, the Ghanaian focus has been on speech surgery, including secondary cleft surgery to improve speech outcomes. So over to you, Roslyn, and looking forward to hear what you're going to share. Thank you.
Thank you so much for that introduction, and hello to everybody in every different country. And it's been very interesting listening to Dr. Eshete. It seems like my talk will pick up on many of the things that he has mentioned. So I look forward to sharing just a broad overview of the role of speech therapy in cleft care. So I'm just, sorry, the first slide is just what has been repeated, the nature of cleft, that it's a very common congenital birth defect. There's failure of fusion of the anatomical structures. This happens in utero, and of course the lip and the palate are formed by the 12th week of pregnancy. So mostly these clefts are isolated defects, but are part of many syndromes, over 400 syndromes, of which it is a multifactorial etiology, and of course many different classifications of the cleft. And the combination of the cleft, lip, and palate is what occurs more commonly than just the isolated lip or palate. And I'm just going to share very briefly some pictures just to cover some of these classifications. So here we can see a microform cleft, a unilateral cleft, the pre and post, the bilateral cleft lip. Here we've got a bilateral lip where it's complete on the one side, incomplete on the other, and of course the palate and the completely involved as well. And here we got late presenting microform cleft, where you can see that the teeth have erupted in these malpositioned manner, but beautiful repair nonetheless. And that is the cleft of the palate and the cleft of the hard and soft. And often what we see, these are not clefts, but these are palates that have been repaired, and then we can see the area of breakdown or fistulae, minute little hole in the hard palate, and then a much bigger fistula, which becomes quite challenging to repair for the surgeons. I have just added these two, the pyroban that we see quite frequently with the underdeveloped jaw. And parents are often bewildered because we talk of a small jaw and want to know what's going to happen in the future. And this to show you or reassure them that they present quite normally looking. This little one you can see has had a tracheostomy done for airway compromise as a baby. And then also commonly through our jaw is the van der Voorde syndrome with the very typical lips. And then finally, I've just added these pictures. When we've done missions out in Africa, I think this may have been in Rwanda, I was my first, and many of the late presenting adults having lip repairs, and we were just blown away. I think, never mind the disbelief of the patient themselves, but many of the volunteers were in tears, absolute tears, looking at these outcomes, which were phenomenal. And this gentleman became the absolute hero. He was an 84-year-old gentleman that had in fact walked to the mission and asked if his lip could be repaired. And just imagine living with this unrepaired lip and these teeth that were protruding. And then the disbelief when this was done. It was just mind-blowing for the volunteers. Everyone was in tears. So, which has been said already by Dr. Eshete, the goal of cleft care is normal facial appearance and, of course, normal speech. And this will be brought about by a multidisciplinary team. And I think just generally that these teams can be huge, but I think the surgeon, the speech therapist, the audiologist and ENT, and of course dentist, orthodontist, should be a minimal team managing treatment. Care is, of course, longitudinal from newborn into the early teens, and timing of interventions is critical. Of course, children development, they're not going to develop, they're not going to have speech for the speech therapist to assess by the time, they're born, they're just babbling. So interventions and timing of them is critical. And of course, last but not least is that the necessary skill and expertise is absolutely vital for positive outcomes. So I think it's just important to know what is the function of a normal soft palate, or what we call normal velopharyngeal closure. We just outlined this palate with some barium, as you can see, and it is a muscular sphincter activity, and consists of the soft palate that will move up and back towards the posterior pharyngeal wall, and then the lateral walls constrict. And so this is why you get the sphincteric closure. And the importance of this is to divide the oral cavity from the nasal cavity and redirect airflow either into the nose or into the mouth. Now, the velum is lowered for the sound to be directed into the nose for the nasal consonants such as M, N, and NG, but it must be well closed for what we call these high pressure sounds that demand oral pressure, P, T, K. And if there isn't velopharyngeal closure, of course, they're going to be the speech problems that everyone's talking about. And we need closure for the vegetative functions of sucking, swallowing, and blowing. I just thought this is a nice picture that shows you the actual nasopharyngeal port, and that all the muscles of the soft palate are in fact paired muscles, and in the normal palate, they're all orientated towards the midline, And in the palate, as it presents, these muscles have an anterior posterior direction or orientation. So what then is velopharyngeal dysfunction, or VPD? Often you will see VPI, velopharyngeal incompetency. These terms are really interchangeable, and what it means is there is no complete or consistent closure of the soft palate for these speech and non-speech activities. There can be 3 causes of VPD. Of structural cause, and this is what we're talking about in the cleft palate, which means that once repaired, of course, that the structural cause of the VPD is the palate is moving well, but it's too short and cannot make contact with the posterior pharyngeal wall. There could be a neurological cause where the palate is long enough, but it just cannot move to close. And then a third etiology called functional or mislearning, and this is often fools many of the doctors, except the speech therapist, of course, where the palate is long enough and it does move, but it doesn't close on a particular group of sounds, such as the S, the Z, the SH. And these different etiologies do call for different treatment approaches, and hence important for the speech therapist to make a differential diagnosis. So what is the impact of a cleft? It does, of course, depend on the severity of the cleft, and it has a potential to affect feeding. It causes hearing and dental problems. There could be a possible language delay. There's speech disturbances, and then, of course, the negative impact on psychological well-being. For example, a cleft lip has a very, affects the aesthetics of the face, but has very little impact on the hearing, or does not impact on hearing, on speech or language delay, just as it would affect any other normal child. Whereas the cleft palate has a normal face, but very definite problems with hearing and language and speech. So what is the nature of these speech disturbances that we are talking about? They really are in a group of resonance disturbances. And by that, I mean the quality of the sound. And as we mentioned, the soft palate needs to direct air into the nose or the mouth, depending on the sounds. And the resonance disturbance we find in many of the cleft palate children, this repair, is that they become hypernasal, that there's too much amplification or resonance within the nasal cavity on these sounds that should purely be oral. There could be nasal emission, that you hear this nasal escape when they're talking, or nasal grimacing or sort of pinching at the nose in an attempt to compensate for this air escape. And then the articulatory disturbances is actually the pronunciation of the sounds. Here we're talking about the predominantly tongue and the lips, whereas, of course, as I said, in the resonance, the structure is the soft palate. So the artic disturbances can be that all the sounds are produced correctly in the oral cavity, but they are simply very weak because of this lack of intraoral air pressure, or the movement of the sounds can move towards the back of the oral cavity. Typically, sounds like TD can become a K and a G, and then we get a group of sounds where they're grossly disturbed and can affect the intelligibility of speech, known as glottal stops or pharyngeal fricatives. I'm just going to stop share screen, and Louis will take over just to listen to this, sorry, Louis, to listen to this speech of this adult who we had seen, and she has a cleft palate that's unrepaired. Could you play it for us, Louis?
1, 2, 3, 4, 5, 6, 7, 8, 9, 10.
Could you just repeat that again, Louis, if you don't mind?
1, 2, 3,
and what you'll
4,
see, the
5,
nasal grimacing
6,
as well.
7, 8, 9, 10.
Thank you. Right. What we saw with this lady is that she was fairly intelligible, her speech. In fact, she had absolutely normal articulation or pronunciation of all her sounds, but they were very weak. And the most disturbing feature here was this nasal quality and this sort of pinching at the nostril level to try and compensate for that air escape. So what is the speech therapy management? So we involved long-term and really from newborn until the early teens. And just to move quickly through this, at newborn, it's the impact here is to establish feeding. Very important to give caregiver education, reassurance and support. And you've heard of, from the previous speaker, the kind of fear and the stress and the stigma that's involved. To reassure these parents that things can be done is vital. And then 0 to 3, we actually focus on language. Are these children developmentally age appropriate? Are they babbling? Are they starting their words at 1 year old? Are they beginning to combine words? Even if it's not intelligible, are they developing language? This is what's important, and we might intervene and teach parents how to stimulate the learning of sounds and combining them. At 3 to 5 years, when we in fact have a speech sample, this is where we look at whether the soft palate is in fact closing well. So we're evaluating the work of the surgeon. So to say, either we're going to start speech therapy or we might have to refer for further surgery. And it's known that 25 to 30% of children might need what we call secondary palatal surgery because of this hypernasal quality. And in our center, beyond 5, there is annual follow-up of children into the early teens because, of course, there are the effects, as we've said before, that the teeth only develop, the permanent dentition at around 10, and the tonsils might be involuting, might be leading to resonance issues. So we evaluate and see if they're on track or not and when things can be done. So it's important to note that speech therapy can only correct faulty articulation. So how sounds are made. We cannot correct this abnormal resonance, the hypernasality, which is due to VPD. And many therapists will sort of focus on blowing and sucking exercises, and this is not indicated because this is not a weak palate. It can move, and it's just that it's not long enough. So no amount of speech therapy is going to make a palate grow longer and contact the posterior pharyngeal wall. So just very quickly, feeding the newborn. It's important to know because this is the kind of information that we do want to import to parents, not just hand over a bottle or an implement, but that they can understand. Newborns, because they have a closed oral cavity and the tongue's moving up and down, there's compression which pushes fluid out, and as the tongue descends with the jaw descending during the sucking action, there is bigger oral cavity, and therefore negative pressure is generated and pulls fluid out. So in a cleft palate child, there's no sealed oral cavity. They have the same reflexive drive to suck and to feed as their non-cleft palate peers, but they're unable to create this negative pressure. So they are sucking, but very little milk is coming from the teat or the breast. And it's often sad, we've seen kids come that are failure to thrive with a posterior just cleft of the palate, and no one has noticed it, and they're trying to breastfeed, and latching is difficult. And once we intervene, you just see the growth spurt take over. Swallowing is not a concern. There's often this fear that they will aspirate. As long as we can get milk into the mouth, these babies can swallow adequately and there's no risk of aspiration. But this is very, very different in the syndromic clefts where full feeding assessment is needed, and it's quite lengthy because of the concerns of aspiration and airway compromise. So just the common difficulties in cleft babies, as we mentioned, there's poor oral suction, they cannot latch, it's an inefficient suck, There might be nasal regurgitation, often not. But I think this is so scary to parents, and they think it's dangerous and try and again allay these fears. Their lengthy feeding times, babies sucking away, getting very little, falling asleep. And of course, there's the frustration of the carer. They take in a lot of air, and there's some discomfort and bloating. This leads to poor weight gain, failure to thrive, and as has been mentioned, then of course can delay surgery and the impact of the other problems. So there are simple solutions. Very importantly, we used to think that feeding the cleft baby is such a challenging task, and it shouldn't be. We provide the explanation. You need to demonstrate. You actually have to teach the carer and address all the fears. Each baby is unique, and so you adjust what is best suited to this baby, and always, always consider the environment, the culture, and the personal challenges of that family. Expressed milk, always preferable. We encourage expressing, and the implements are simple. You can use a cup, a spoon, a syringe. Soft compressible or valve bottles are commercially available, but of course is more challenging for sterilizing. We often do cup feeding in the more, poorly resourced families. But again, you have to teach them about positioning the infant for safety, frequent winding. We do say complete a feed within 30 minutes to avoid fatigue, but the full amount of the volume should be given. And very important is that we encourage them to place the baby at the breast for non-nutritive sucking in between feeds, which is great for baby, for mom, encouraging milk supply. Orthodontic feeding plates are often talked about, but they have absolutely no use. Of course, there's a burden of care with these. They have to keep on being made, but all they do is they close off the hard palate, but you've still got the soft palate that's open, and therefore the same concerns of a cavity that is open. And the dietitians, of course, have to be on board to advise on the type of feed if it's alternate and the volume. And just to show you here, the natural sucking reflex of this little one, the first time the bottle is put in, and a happy baby, a happy dad, semi-recline, and you can see the jaw excursion, and in fact, the milk flow into the mouth. You can see the little bubbles there. So just in completing the hearing impairment, why is there a hearing impairment? Because a normal ear is an air-filled cavity without fluid, and drainage from the middle ear takes place through eustachian tube, and this is opened by the tensor tympani muscle that joins the big muscle of the soft palate, the levator. And if the levator isn't working well, then neither will the tensor, and therefore we get a buildup of fluid in the middle ear with possible inflammation, and these babies then are at risk for this fluctuating conductive hearing loss, and it can persist. It's quite chronic. So treatment by antibiotics and grommets will be decided by the ENTs, and it's of note that the early hearing loss, even if it's intermittent, can have more an impact on speech and language development, more so than the actual cleft itself. So very important to monitor, to screen later on, if possible, to do behavioral testing and referrals if need be. So in closing, what do we do later on to assess the speech? We have to know if there's velopharyngeal dysfunction and what to do about it. Of course, we do a case history and an oral exam, but the speech assessment is a clinical subjective assessment where we really listen to abnormalities, and the primary tool is our ear. That is, in fact, the gold standard listener judgment. Of course, you have to be experienced. You have to know what kind of sample to use to elicit what you're looking for, the resonance and articulation disturbances. There is instrumental assessments that are available. We do lateral X-ray, video fluoroscopy, the movement of the soft palate, but it's simply there to confirm clinical judgment. If you have a trained speech therapist, we do not do this routinely. And of course, it is dictated by the compliance of the child. And here I'll just show you, this is a normal palate. This is what lateral video fluoroscopy is. You can see the wonderful velar stretch of a normal palate with a nice right angle knuckle contacting the posterior pharyngeal wall. So when is the ideal time to repair a cleft palate? As we've heard with the speaker before, the earlier the better, to minimize the impact of all the problems that can be associated by an unrepaired cleft palate, and as Prof or Dr. Eshete has said, by a badly repaired cleft palate. Yes, there are ongoing debates and research regarding the timing and what kind of repairs are best suited, and cleft units have their own bias and surgical treatment protocols. So thank you. There's just one other slide. I think I might have a minute. Just that I work at Red Cross, which is an academic tertiary hospital. So we have the benefit of a multidisciplinary team and also referral pathway if there are any of these syndromic clefts that present. So it's an outpatient clinic on a Thursday morning. The patient will see every team member on the same day, and post-surgery we do annual follow-ups into the late teens. And just thought stats, during 2023 we saw about 234 patients, 39 were new. Of course, this is not the number of surgeries because it will be primary surgery and many of the kind of revisions that are needed. So thank you very much.
Thank you very much, Roslyn, for sharing your wealth of experience and knowledge with us. I certainly found it very interesting to hear about cleft lip and palate from the speech therapist perspective, which is not something I've heard before with such an amount of knowledge. So thank you very much. I see there are a number of questions coming through. And if we can just ask for those that are sharing questions on the chat and also putting their hands up at the moment, please can you just write those questions in the Q&A? And they will be responded to at the end during the panel discussion. So thank you. Please keep doing that. And now I'd like to introduce our third speaker, who is Kwaku Obuobisah, and he is a speech program coordinator in Ghana, specifically working with Operation Smile. So over to you, Kwaku. Thank you.
Okay, a good afternoon, all the way from Ghana. So my name is Kwaku Obuobisah, and I am the speech program coordinator for Operation Smile Ghana, a role that I have occupied for the past 2.5 years. Prior to that, I have coordinated projects targeting mostly interventions around children suffering from communication disorders, physical disorders, and other forms of disorders here in Ghana. I've worked with organizations like World Vision, and currently in my role as a program coordinator for Operation Smile Ghana. And I want to thank the organizers also for this beautiful webinar. I am learning a lot, and I see Roslyn also on the call, who has supported us since we started this program about 3 years ago here in Ghana. Okay, so to Operation Smile, what we do as a foundation, we are concerned with creating or having the vision to create a future where dignity and then the health of patients will be improved by safe surgery, through safe surgeries. And as a mission, we leverage so much on the technical expertise of our volunteers that we have here in Ghana and also across the globe. We work currently in over 30 countries here in the world, And also we have provided over 300,000 surgeries to children who are born with cleft lip and then cleft palate conditions. We have an array of health professionals that we work with, not just surgeons, but also pediatricians, anesthesia, nurses, speech and language therapists, and also dentists as well. Here within the Sub-Saharan region, most of the time people have asked how huge is even Africa. And so this slide looks at how vast Africa is, not only in terms of demography, but also how these respective countries fit in easily into Africa, which is even different in terms of the cultural differences we have here, the political differences we have here, the economic differences. And these footprints are areas within Africa where Operation Smile is found and contributing together with our key stakeholders and partners to improve the health and dignity of not only patients who are suffering from cleft lip and palate, but also their communities as well. Within the Sub-Saharan region, we operate in 9 countries. Ghana is the only country here within West Africa that is a foundation office. A foundation office means that a country that implements directly interventions to improve the health and dignity of the patients through quality safe surgeries. And then we have foundations that are mostly concerned with fundraising. But within West Africa, Ghana is one of the few foundations that implements program targeted at providing quality surgeries to our patients. Down south in Africa, we have other countries like Malawi, Mozambique, and Rwanda that are also contributing towards having the same overall objective or goal that we have as an organization. So the question that we have been asked on a daily basis is that, what would you do if she was your child? And that is one question that has informed our strategic objective, our strategic direction and goal, our action plans, our country plans, and what we have to do. Dr. Eshete and then Roslyn have said a lot about some of the emotional displays of caregivers and also the direct effects on a child who suffers from this condition that informs the array of comprehensive care that we provide as a foundation. And so as a caregiver, if you have a child like this, immediately you would know that the self-esteem of this child is of concern. You would immediately also know that feeding may be also of concern. Depression may set in, the patient or the caregiver will be frustrated, and that informs what we should do going forward every step of the way throughout identifying a patient through to after the patient receives surgery, and also going into other comprehensive care that such a patient will require. So Operation Smile, we have an array of care or continuum of care that we provide. First off, we begin with identifying the patients who are the primary beneficiaries of our interventions. Africa is huge, Ghana is equally huge, and the task cannot be handled by a few people. And so we work closely and collaborating with key stakeholders, the Ministry of Health, the Ghana Health Service, there's the Ghana Education Service who are currently also on board, where volunteers are trained on how to identify patients, how to register these patients, refer these patients to be able to receive care. There is continuous training for these patient advocates and volunteers, as well as community health nurses, to help us contribute to our overall objective that we want to achieve as a foundation. Once the patient is identified, the patient needs to have a surgical plan, because once you get a patient, what plan do you have for the patient? We sequence this patient through a series of care. Sometimes these patients will require nutrition rehabilitation. And as a foundation, we have nutrition programs that we run on a monthly basis, where we take the patient through the program, providing them with ready-to-use therapeutic foods that would help them improve or enhance their weight prior to surgeries, make sure that their nutritional status is appreciable before surgeries are conducted for such patients. Sometimes the patients will go right into surgeries, but afterwards will require other complementary care like dental or speech and language therapy, and sometimes psychosocial as well. The surgical aspect of our operations looks at providing the surgery itself for the patients that are in line with global standards and conduct as a foundation. We rely so much on these standards. They are standards that we do not compromise upon. For example, for a patient to receive surgery who is a cleft lip patient, such a patient should be around 6 months and above. And then for a palate patient, the patient should be 1 year and also above. These are standards that we do not compromise on. There may be few deviations here, but those are, they need to be approved by the medical directors and the medical officers at the regional levels. There are also few barriers, in fact, a number of barriers that patients need to overcome as they assess surgeries, and we come in to provide that care and also bridge that gap in order to bridge the barriers that these patients would have to overcome to access care. We also provide a post-op follow-up for patients extending up to 18 weeks after surgeries. When the patients require dental, we are there to provide that dental care. When patients require speech and language therapy, we're working closely. And then when patients also require other forms of comprehensive care, we are also there. Post this continuum of care, we look to empower these patients and train them to also be ambassadors to help us in recruiting of patients and also to support caregivers who have children who suffer from some of these conditions. Believe me, some of these patients and their caregivers would rather prefer to stay at home and not bring their children out due to stigmatization. And it takes a child or a caregiver who has received such a surgery to convince a mother to bring a mother to bring her ward to receive such a surgery. So Ghana as a whole, this is just a Ghana flag. That brings us to what we do as a foundation, narrowing it down. Operation Smile started in Ghana in 2011. Together, we have provided over 20 surgical programs. We have graduated from the mission, the traditional mission approach, where we have international volunteers fly into Ghana to provide care, and afterwards they leave, now to a more sustainable approach where we train local surgeons, and the interventions are more locally driven and internationally supported. Together, we have provided surgeries for over 2,000 patients here in Ghana. We have supported over 2,000 children who have suffered from nutritional needs and will require rehabilitation. We do not work we do not work alone. We work closely with partner hospitals. We have a concept of a hub and spoke model where the hub, which is Kolebu Teaching Hospital here in Ghana, strengthen the spoke hospitals in other regions. That includes the Eastern Regional Hospital. There is the Tamale Teaching Hospital. There is the Cape Coast Volta. These hospitals, we look to strengthen them so that in the long run, they will also be equipped enough to provide quality surgeries for patients. As we're doing this, we are training healthcare professionals in this array of comprehensive cleft care every step of the way to ensure that the interventions we provide become sustainable in the long run. So this slide talks more of our footprints here in Ghana. Kolebu, which is in the southern part, and then we have the Tamale Teaching Hospital also in the northern part. 4 currently within the southern and only 1 up north, means we still have work to do to strengthen other hospitals in some of these northern areas to be able to provide the care that we provide for our patients. Now, let me introduce you to the Speech Dream Project. This project is one of the flagship interventions that we run as a foundation. It is a project that is funded by the Swedish Postcode Lottery. It's been in Ghana for 2.5 years. We are in the 3rd year of implementation. And in 2025, this project is going to gradually close out. And the objective of this project mainly is to break the barriers to audiology, speech and language therapy care here in Ghana by 2025. We're looking to provide care to direct beneficiaries, totaling 8,700 patients, as well as their caregivers. It's a small team made up of the project coordinator and the monitoring and evaluation officer. Of course, we are supported heavily by the team in HQ, that is headquarters in Virginia, and then also foundations here within the Sub-Saharan region, including South Africa as well. Now, what led to the execution of this Speech Dream project? Prior to the execution of this project, a baseline was conducted, and from this baseline, findings that led to the execution of this project were set in motion. We realized that out of every 15 children that we encountered, 1 out of them suffered from communication disorder, being it onset fluency, other communication disorders that probably they didn't even know, other behavioral conditions that they presented with. And we also found out that it was not only children who suffered from cleft lip and palate who had communication disorders, but other conditions like cerebral palsy, autism, Down syndrome also affected the communications of children as well. Prior to this speech project also, there were less than 5 speech and language therapists here in Ghana, and most of them were skewed towards the southern part, and most of them were also trained in the UK, but not here in Ghana. Another major gap we identified was that as a country, there was no clear national policy when it comes to speech and language therapy care delivery here in Ghana. And so professionals who were practicing here in Ghana were not found within the Ghana health service system. They didn't have national approved job descriptions, and for that matter, they were not earning their right wages. And because of that, the profession wasn't even interested or attractive to health professionals who wanted to engage in this profession. The Speech Dream project drives on 2 main wheels. That is the service or the care delivery wheel, and then the capacity building wheel. The service or care delivery wheel makes the service available or intends to make the service available and accessible to patients who require this care. And so in this pool of care, we want to establish speech and language therapy clinics here in Ghana. We also intend to invest or expand into audiology here in Ghana, because we realize that audiology is also a key component when it comes to speech and language therapy. Because of the high caseload here in Ghana, we seek to also deploy mobile clinics into the northern parts of Ghana, middle belts of Ghana, and also the southern regions to provide that care to patients in remote areas who encounter barriers in traveling far and wide to access care in these established clinics. Also, there is a misconception when it comes to communication disorders and also speech as a whole. Some caregivers or community members perceive it to be a child who suffers from communication disorders as someone who, as we would term in our country, someone who is sick or doesn't have the right to even be amongst his or her peers. They suffer lots of stigmatization. And so we seek to demystify some of these misconceptions through an intervention we call the language enrichment workshops. And then also, as Rose and Dr. Mekonen said, some of these children will require additional surgeries in order to improve their speech. And that is what we term as speech surgery. They are surgeries that are determined by the speech therapist and then also the plastic surgeon. They take the patient through a series of assessments and to also know the technique to even use whether it being a repair of the palate or any other approach that they need to take to improve the communication or the speech of that patient. The capacity building aspect also looks at training health professionals who, in partnership with the University of Ghana, we are taking them through a 2-year master's program. When they graduate, they take their 1-year internship and graduate as speech and language therapists here in Ghana to increase the pool of speech therapists we have here and also improve the quality of practice here in Ghana. Now, the University of Ghana itself requires lecturers to be able to provide this research and also academic needs in order to bridge that gap. And so we are supporting their PhD candidates. There's one candidate currently who is studying with the University of Cape Town in South Africa. And he is also looking to finish, graduate, come back to Ghana to support the education here in Ghana. We are also supporting them with visiting professors through our partnership at Sweden, University of Karolinska, and also University of Cape Town as well. The speech surgery is a new area, and so we need to also train surgeons on how to perform these surgeries. They are quite complex, how to perform these surgeries effectively and efficiently. These are a few indicators and how far we've come since 3 years into the project. We have been able to establish 2 speech and language therapy clinics, one in Eastern region and then one in the Northern region. The one in the Eastern region is the first of its kind within the Ghana Health Service System. And then the one in the Northern region is in partnership with a teaching hospital. Altogether, these 2 partner hospitals have been able to provide care for 2,330 unique patients. Now, the question I ask myself is, where would these patients have been if these clinics were not established in the first place? Because of the high caseload, we have been able to also procure and deploy 2 mobile clinics. These mobile clinics go around once every week in the Eastern and then the Northern regions to provide care to patients who suffer from communication disorders. And we do this in partnership with partner hospitals and then also the Ghana Health Service and then the pool of speech and language therapists and audiologists that we have here in Ghana. We have also been able to reach over 900 caregivers on messages on how to demystify some of these misconceptions when it comes to speech and language therapy. And we have been able to develop a manual in partnership with the Speech Council. Roslyn was part of the team, and it is a very beautiful manual. It fosters communication at the community level with caregivers as well. The mobile clinic in total has been able to provide care to 1,400 patients, over 1,400. And then also we have provided speech surgery to 90 patients who have now attained functional speech. And some of them are also in therapy sessions to improve upon their functional speech. Prior to this speech program, like I mentioned, the speech and language therapists here in Ghana were 5, less than 5, but currently we have 53 who have graduated from the University of Ghana and are practicing to support the care delivery here in Ghana, who also undertake and undergo series of trainings whenever there are surgical operations or surgical missions here in Ghana. What does the future look for us as a foundation and also as a project? We are looking to invest heavily in audiology care. I must say that this program or project was designed, first of all, with speech and language therapy being the initial thoughts. But along the way, we realized that audiology is also a key component because before a patient requires the therapy or receives the therapy, we have to rule out hearing. And that is where audiology comes in. And so we've been able to procure 4 OAEs or otoacoustic emission devices, which we expect in country next month to complement the care that we provide. And thankfully, we have the audiologists here in Ghana who are skilled and trained to be able to support the process and encourage the use of some of this care also here in Ghana. We are also supporting the PhD candidates through the University of Ghana, where currently one is studying with the University of Cape Town. And we look to also invest heavily in that area to ensure that the lecturers have the right skill sets, they are qualified to be able to ensure that we bridge that knowledge gap and improve the care and practice, and also invest in even research and publish findings to contribute to the body of knowledge when it comes to speech and language therapy, as well as audiology here in Ghana. I want to share a story of one of our patients called Nathaniel Steele, who was born in the Eastern region. Nathaniel was born with both a cleft lip and then a cleft palate. He was fortunate to receive his surgery in 2015. That is the first one, the lip, and then continued with the palate surgery in 2017, 2 years after that. So between 2017 and 2022, Nathaniel did not have any speech and language therapy sessions, did not have any assessments to even determine that a speech surgery will be able to improve upon the speech of this child. And then when the project came in and the speech surgery was also introduced, Nathaniel received his second secondary palatoplasty or palate surgery. And now Nathaniel went on to receive 3 months of therapy sessions and was cleared by the speech therapist as having attained a functional speech. Nathaniel is currently in primary 3 in school. He's doing very well. His speech has improved so much. And it's also thanks to the various stakeholders we have, the pool of volunteers who work with us to ensure that a boy such as Steele attains functional speech and intelligible speech as well. So on the project, we have a number of partners. The Swedish Postcode Lottery is one, University of Ghana, Operation Smile itself, foundation level, and then Tamale Teaching Hospital, Ghana Health Service. We have the University of Cape Town, the Kolebu Teaching Hospital as well. We involve in the Ministry of Health and the Ghana Health Service greatly because of the policy aspect of it, and also Ghana Education Service. It is time that Ghana develops a clear national policy when it comes to speech and language therapy. We need to place these speech therapists within the structural system here in Ghana, make sure the care or the practice is attractive to speech therapists, is attractive to individuals who want to pursue this career, so that as a whole, we'll be able to contribute to the overall objective of ensuring that children attain functional speech. So these are some pictures. We can see Roslyn Lentin with some of the trainees here in Ghana during the speech surgical program. There are international volunteers taking us through also the language enrichment booklets, which we have developed in partnership with them. And also the trainees within Ghana, they are all students who graduated from the University of Ghana, which Operation Smile supported in partnership with other stakeholders here in Ghana as well. So thank you very much. This is the end of my presentation, and Medase.
Thank you very much, Kwaku, for a really comprehensive presentation, and I think just bringing us such positive news from Ghana and what's happening there, especially coming from a perspective without having a recognized or accredited speech therapist and so on. I think amazing things are happening there, and perhaps a model that could be for other parts of Sub-Saharan Africa. So thank you very much. And I'm going to move on quickly to our next speaker. We are rather running behind. So I'd just like to remind our remaining speakers to try and stick to your scheduled time so that we still have time for questions. Otherwise, we may run over a little bit. We want to try not to do that. So I'd like to introduce now Dr. Thirona Naicker. She's a pediatrician with an interest in genetics, and she is based at Nkosi Albert, the Tuli Central Hospital in KwaZulu-Natal, and also at the University of KwaZulu-Natal. She's going to be speaking on syndromic and non-syndromic OFCs, including the etiology, the clinical evaluation, and prevention. She qualified 21 years ago as a doctor and became a specialist pediatric pediatrician in 2009. For the last 14 years, she's been employed as a specialist pediatrician in medical genetics at IALCH in Durban. And she provides both in and outpatient services to children born with congenital disorders. She's also involved in outpatient clinics, including multidisciplinary genetics, neurodevelopmental, craniofacial, and dermatology clinics. And over time, she does as well. I don't know how she fits it in the pediatric ICU, high care, and COVID ICU. And to top it all, she finished her PhD in 2022, which was focused on the genetics of orofacial cleft. And so without further ado, Thirona, over to you. Thank you.
Thank you, Helen. And thank you to sSCAN for this opportunity to be able to share some of my experiences with orofacial cleft. My role in the webinar today is to talk about the clinical aspect and from the pediatrician point of view, what we look for. So I'm going to be talking about syndromic and non-syndromic orofacial clefts. So by means of introduction, just to talk about the epidemiology, we know that orofacial clefts is one of the most common birth defects. And here in South Africa, it's one of our top 5 priority conditions that we list. We know this figure where it says that orofacial clefts affect 1 in 700 births worldwide. And this is the overall figure, but the prevalence in Africa is given at a lower rate of about 1 in 2,500. And my belief for this is that we don't have that many birth defect registries in South Africa and in Africa, and that's why the number that we may be recording may in fact be lower than what it actually is. There are many different ways to delineate the different types of clefts, but the most common way is to look at what we see anatomically, so the anatomical phenotype. So we can have a cleft lip only, we can have a cleft lip and palate, and we can have a cleft palate only. The first two, so cleft lip only and cleft lip and palate, are often grouped together, and we call them cleft lip with or without cleft palate. And this is mainly due to the embryology and the epidemiological patterns in the world. So in terms of the genetics, we say that orofacial clefts are divided into either syndromic or non-syndromic orofacial clefts, where non-syndromic means that this is the only birth problem in the patient, whereas syndromic, there may be other congenital anomalies that are present, either the heart or the kidneys or the brain. We say that orofacial clefts is multifactorial, and it is due to an interplay between the genes and environment. And what I mean by this is shown in this diagram, where in syndromes, there may be a specific gene involved, and we're going to talk about that shortly in the next few slides. But in non-syndromic, there may be an interplay between some environmental factors and some gene factors to get the presentation of a cleft lip palate that's non-syndromic. So in terms of syndromic cleft lip palate, if we look at the OMIM database, which stands for Online Mendelian Inheritance in Man, there are over 500 syndromes listed that have a link to cleft lip and or palate. What we know is that with cleft lip, with or without cleft palate, 30% of all patients are syndromic. That means 70% are non-syndromic. Whereas when we look with cleft palate only, 50%. So half of patients with cleft palate only are syndromic. So we must look for the other congenital anomalies. So the next few slides, I'm just going to take you through 5 common syndromes that I see at the clinic quite often. So the first, some of my fellow presenters have alluded to this condition, is van der Voorde syndrome. So it is the most common form of cleft lip palate, where 2%, it occurs in 2% of all syndromic clefts. It is known as autosomal dominant. So if a parent is carrying the gene, there's a 50% chance of him or her passing it on to their children. The gene that occurs with van der Voorde syndrome is the IRF6 gene, and about 30 to 50% of mutations that occur in the IRF6 gene are actually new or de novo mutations. It can present with a cleft lip with or without cleft palate, or a cleft palate only. And Roslyn mentioned these, that sometimes we see these bilateral lower lip pits or the indentations, and that is often the clinical clue that you're dealing with van der Voorde syndrome. Penetrance ranges between 89 to 99%, meaning if the patient is carrying the gene, they may not always develop the syndrome. It occurs in, at 89 to 99% of all patients. And then in genetics, we have another term called variable expressivity, which means even if you have the gene, in the same family, different family members may present differently. Some may just have the cleft, may just have the lip pits or the missing teeth, whereas the others may have the full spectrum, including the cleft palate or the cleft lip with or without cleft palate. There's another closely related syndrome known as popliteal pterygium syndrome. It is also found, it's allelic on the IRF6 gene, and it is more severe than van der Voorde syndrome in that you get webbing behind the knees, so you get these popliteal pterygia. The next syndrome I want to show you is something called Treacher-Collins syndrome, also autosomal dominant like the previous one. Mutations occur in the TCOF1 gene, which is on chromosome 5. And the features are you sometimes can get a very small jaw, so severe micrognathia, ear abnormalities where the ear is malformed, microtia, because of this conductive deafness. This part of the face, you have malar hypoplasia, so there's flattening of the cheek areas, and at the lower lid, lower eyelid, you get what we call inferior lid colobomas, or these little cuts that occur, and that's often a clue for Treacher-Collins syndrome. Roslyn mentioned Pierre-Robin syndrome. So here you get a triad, and the condition occurs because of a sequence of events. So the first thing that happens embryologically is that the jaw is micrognathic, or it doesn't form as nicely when the baby is developing or the fetus is developing. And because of that, the tongue stays posterior and high and small, and this is called the glossoptosis or the small tongue. And because the tongue is high and posterior, there's formation of this large U-shaped cleft palate. And with the combination of all of these things, the child often has upper airway obstruction when the child is born. Severe cases may need distraction, and we've had patients in ICU where we've had to hang bags over the back of the bed to actually assist the jaw and retract the jaw. So Pierre-Robin sequence may be an isolated finding, meaning that may be the only thing wrong with the child, or it can occur together with other syndromes. So there's an underlying etiology or gene, and sometimes we have it with Stickler syndrome or deletion 22q11 syndrome, which I'm going to show you in the next 2 slides. So Stickler syndrome is autosomal dominant. We have congenital myopia, so short-sightedness. There's midline clefting, Pierre-Robin sequence, like I mentioned, deafness, and this picture here is showing the quite hypermobile thumbs. There's mutations in genes known as COL2A1 or COL11A1, and it's another clinical syndrome that you can see. Deletion 22q11.2, many of you may know it as DeGeorge syndrome. It's the commonest microdeletion syndrome. So it's usually 3 megabases of genomic material that's deleted. It can be detectable by various tests, such as a FISH or an MLPA or a microarray. It's also autosomal dominant. And how we see this syndrome clinically is we look for something called the catch-22 mnemonic, where each letter stands for something. So the first C is for conotruncal cardiac abnormalities, and it's typically an abnormality on the aortic arch. Typically, the patients get tetralogy of Fallot, an abnormal face, so you can see quite a long face, a square nasal root. In the infants, there can be thymic hypoplasia that will be seen on seen to be missing. So the thymus seen to be missing on the chest X-ray. And then here you can see that the cleft palate is often midline and posterior. Hypocalcemia is another thing that can occur, especially in the neonates, and often very difficult to treat. These patients with DeGeorge syndrome often have immunodeficiency, where they have a reduced T cell count and CD4 count. They can have nasal speech and often speech delay as well. So in terms of what I look for in the clinic is a clinical approach. Just one quick slide on prenatal is that sometimes you are able to detect a cleft lip at 20 weeks of gestation, but it's very much dependent on the expertise of the ultrasonographer and the size of the cleft. So you can see that a cleft lip will be easier to be seen on 3D imaging, whereas a cleft palate that's inside the mouth would be more difficult. And some of the advantages of prenatal diagnosis is you have some time for parental education, for psychological preparation, and to investigate for other anomalies. In terms of what we do at our clinic, we take a history and we look at a 3-generation family tree, and we ask questions about previous clefts or previous individuals with missing teeth. We take a pregnancy history looking for anticonvulsant medication and steroids. We ask if there was any decreased amniotic fluid or oligohydramnios in the pregnancy, and in brackets are the conditions that that sign or symptom is linked to. Maternal diabetes is a risk factor. We ask if there was any vision problems in the family, and if there was delayed speech and development or schooling difficulties, and if there was anyone in the family that had hypocalcemia, immune deficiency, and cardiac anomalies pointing towards the deletion 22q that I just mentioned. On examination, there's a lot of things that I look for in the clinic, and we examine each patient to make sure that they don't have these things. So short stature, any type of skeletal abnormalities. In the mouth, we look for lip pits, oral frenula, and ankyloglossia is the tongue tie. We look for differences in the facial features, so some coarse facial features. If there's the lacrimal duct that's absent, if there's a flat mid-face, like I showed you for stickler, we look at the chin if it's small. We look at hands and feet for extra fingers and toes, for missing or claw hands. In the limbs, also contractures, webbing of the knees and elbows. The heart is examined for murmurs and defects, and any genitalia abnormalities are looked for. We also make a note to examine the parents, because sometimes a parent may have a submucous cleft, a bifid uvula, or lip pits that have been missed. Lots of investigations can happen, but it's very patient-specific. And we decide in our clinic if we need to do, for example, a FISH test or an MLPA or a microarray. Unfortunately, at our clinic, we don't have access to gene panels, whole exome sequencing, or whole genome sequencing. If there's, for example, a condition known as Smith-Lemli-Opitz that we're suspecting, we can send off a cholesterol test. The patient gets referred for, as part of the dysmorphology workup, an echo, a renal ultrasound. If ophthalmology is needed, that happens as well. And there are some specific gene mutations that occur with specific clinical syndromes that we see. So like I mentioned, in van der Voorde syndrome, you can get the IRF6. In the ectrodactyly, ectodermal dysplasia and clefting, it's P63. And in X-linked cleft palate with ankyloglossia, it's TBX22. And these are very common cleft genes. There are some cleft panels, and these are some of the common genes that can occur. In my PhD on cleft lip and palate, we looked at some of the common gene mutations. So like was mentioned by my previous panel speakers, is that the management is very much multidisciplinary, and it includes a huge list of people listed here. So neonatologists, pediatricians, orthodontists, depending on your center, whether it's the plastic surgeon or maxillofacial surgeon that operates, ENT surgeon with the audiologist, geneticists, nurses, speech therapists, psychologists, social worker, and dietitian. This is a photo from our multidisciplinary clinic. You can see we don't have much. It's just a few tables that we put together, and there's different disciplines sitting at each table. Here I am in the corner with our nurse, and the patient goes through all of the different stations, and it's a way that the patient can come and see multiple different specialities and people and only come for one visit. So the patients love it, and we get a lot done at these clinics. Some of the pre-surgical orthopedics or maneuvers that get offered at our clinic, one is lip taping. So you can see here, it's actually the shin splint tapes that we use that are cut appropriately. And what this does is it reduces the cleft size and it actually assists in the final surgery. It also assists by creating partial obturation, so that helps the baby to create a better suck to feed. We also offer nasoalveolar molding. So it is where sometimes you can see there's an asymmetry of the nostril. So in the first 3 months, the newborn cartilage is soft and it can be easily molded. So the orthodontist that I work with in the clinic, he actually makes this little contraption which lifts the nostril. And believe it or not, it's made with a paper clip and it's actually quite successful. There's also some patients who actually have a real difficulty in swallowing and they may need plates to be made for them. This is not very common, but if it is needed, the orthodontist will take a mold to have that done. Prof. Eshete mentioned the surgical options. For us at our clinic, our primary lip repair happens at 3 months. If there's a cleft palate, it happens at about 9 to 18 months. And then thereafter, from about 8 to 10 years, we offer orthodontics and alveolar bone grafts if the patient needs it. I've just got 2 more slides. So I was asked to mention a little bit about the recurrence risk. If you look at the literature and at textbooks, there's big tables that show you if you have a 1st-degree relative or 2nd-degree relative, what is the risk? I just want you to remember these 3 points, which is if there's a positive family history, then the risk of having a cleft lip with or without cleft palate is higher. If there's an affected parent, then there's a 3 to 5% risk of that parent having a child with cleft lip with or without cleft palate. And if those parents have 1 child, there's a 40% chance of having another child with cleft lip with or without cleft palate. In terms of prevention, there have been multiple studies and lots of research, whole papers dedicated to each of these things. But in general, what we know is that there's a risk of having a child with cleft lip and palate if a mom smokes, if she takes alcohol, especially a binge intake, if she's on anti-epileptics like phenytoin, valproic acid. So there may be a suggestion to see if it can be replaced, especially in the 1st trimester of pregnancy. If she's on corticosteroids for whatever reason, if she has a folic acid deficiency, if there was a risk of hypothermia, especially in the 1st trimester, diabetes mellitus is a huge link as well. And if there's obesity in the mom, there's been a link to having a child with cleft lip and palate. These are some of my references that I've used. And I just want to thank my mentors through my projects. This is the Butali lab members with Prof. Butali here at the background. Smile Chain, who assisted me with funding for my project, and all of our patients without which the work would be impossible. Thank you so much.
Great. Thank you so much, Thirona, for a really comprehensive overview. I loved it as an epidemiologist and really enjoyed the genetics. And it leads quite nicely into our next talk, which is being given on behalf of Professor Azeez Butali, who unfortunately is currently on a plane back from the World Health Organization meeting back to Iowa. So in his place, he has requested that Dr. Azeez Alade actually present his talk, which is going to be on Genome to the Community, Lessons from Orofacial Clefts Research. And just to quickly introduce Dr. Azeez Alade, he is a clinical research fellow at the National Institute for Dental and Craniofacial Research at the National Institutes of Health. He obtained his Bachelor of Dental Surgery with intercalculated BSc degree in Human Physiology at the University of Lagos in Nigeria. He also went on to complete his master's and his PhD in epidemiology or genetic epidemiology at the University of Iowa, which he graduated in 2021 and 23 respectively. And he's earned a number of certificates in biostats and college teaching. And just to pick a few things from the rest of his bio, he's also seems to be really committed to helping build up capacity and advocating for improved mentorship and capacity in the area of OFC. And he is sharing his journey into genomic research to encourage aspiring minority students interested in research. And just finally, before I hand over to Dr. Alade, can I just ask that our other panel speakers just go through the Q&A section, and if there's a question that's relevant for you to respond to, please go ahead and respond so that we can focus on, we're going to have very little time for questions, so we can focus on a few remaining questions at the end. Thank you very much, and over to you, Dr. Alade.
All right, thank you so much, Helen. Can we hear me well?
Yes, loud and clear.
Okay, thank you so much. Okay, so just like Helen mentioned, I'm going to be delivering this talk on behalf of my mentor, Dr. Azeez, who is unavoidably absent. But again, I think I was also involved in some of this project, and I think that's something that I would be able to share with you as I go through this presentation. So the title of the talk here is just sharing the African cleft research journey. And I'm going to start with the genetics and then end with community engagement and mental health. Okay, so again, I'm going to give us a brief introduction on the background. I'm not going to spend so much time on this because I think many of the previous speakers have dealt on the background of orofacial clefts. So I'm going to talk about genetics and how we have leveraged collaboration to move the field forward. And then I'm going to end on community engagement and mental health of caregivers. So again, just to give us a little bit of introduction, we know that orofacial cleft is one of the most common birth defects. And all these things that I'm showing on this slide is just to show us that this condition still remains a major public health problem. And as we can see, there is still infant mortality that result as a result of this orofacial cleft. And just like previous speakers have mentioned, there is a psychosocial impact to this, and there is a need for multidisciplinary team, which is usually not available in most parts of Africa. So before I go into a lot of my talk, I wanted to take a break and then talk about something we did in 2022 when we reviewed most of the research on clefts, is that we found out that the basis of discovery in terms of genetic studies of clefts is actually accurate phenotyping. And so what I mean by this is we know that there is a problem with cleft registries in most African countries, and so we don't even have accurate incidence estimates. And these are very important when we talk about genetics, because you need to be able to accurately determine the prevalence of some of these conditions to start thinking about the frequency of some of the variants that could be driving this phenotype. And so I'm going to start with the work of my mentor, Dr. Azeez, who started back in 2006. And so he moved through the different states in Nigeria, trying to collect samples for saliva samples from patients that have orofacial clefts. Now, at this point, he was able to gather some samples, but then these were only enough to do what we call candidate gene study. The reason being that candidate gene studies were just designed to sort of test the hypothesis that some of the genes that were reported in other populations also contribute to orofacial clefts in the African population. And while we identified some of them to be true, we also learned that there were different variations in the same gene. So not the same variation. So you could have one variation being significant for the African population, whereas you could have other variation in the other population. And this is not surprising because if you remember, the African population is the ancestral origin to modern humans. So what happens is as people migrate away from Africa, there is the bottleneck effect and some of the variation are being lost. And that's why what we're noticing is some of the variation we're seeing in the African population is absent in the other population. So this effort led to, this effort was later sponsored by Wellcome Trust, and so they were able to gather more samples from other African countries like Ethiopia, as well as South Africa and also Ghana. And so putting these samples together, they were able to do the first African Genome-Wide Association study on non-syndromic orofacial clefts. And so just a quick introduction of what a genome-wide association study is. This is a study that seeks to interrogate the whole genome to identify variants that are likely associated with a phenotype. So basically, you're looking at the frequency of these variants to see, is it more common among those that have the condition as opposed to those that does not? And typically, the result is usually presented in this format, where we call it the Manhattan plot. And so what you can see here is that in this first African Genome-Wide Association study, we identified novel variants in 2 genes. One is the CTNNA2, and the other one is the SOL2A1. The interesting thing is that none of these have been previously reported in other populations, which also show the uniqueness of the African population. In this study, we did replicate some of the previously reported variants in other populations, like the variant in the PASH1 gene, which I'm showing down here. And so this was the first major study in orofacial cleft in Africa. But with this particular data, then we can start looking at other secondary analysis. And one of the other secondary analysis that was done was a study that was led by Wahid, another member of the Butali lab, who wanted to know if there is a gene by sex interaction, because we know that the prevalence of orofacial cleft vary by sex. And so he was interested in knowing, does this risk loci, do they also influence the phenotype differently based on gender? And he actually identified a locus, which is in the H322 locus. And if you can see here that with the variant allele, the risk tends to reduce in male, whereas it tends to increase in female. And so that shows us that there is some gene by sex interaction. So this work is already published. I myself was also interested in knowing that. So when we do genome-wide association study, one of the things that is challenge is that because we are doing multiple SNP at the same time, we have to correct for multiple testing. And so one of the problems that arise from that is you might not be powered enough if you don't have a large sample size. And so one of my questions was, we always would have a lot of SNPs that falls in the suggestive association range. Is there a way we could identify a potential true signal in this suggestive range? And so to do this, what I did was to select all those SNPs that falls within the suggestive range and try to replicate and do a meta-analysis. And doing this, I was able to identify a lot of SNPs within the 8q24. This 8q24 locus is actually a common locus for cleft lip with or without cleft palate. Another one that's interesting was a SNP that is near chromosome 9, and this is actually very close to the PASH1 gene. Now, the next thing that I'm going to show you is how we have been able to move from just identifying SNPs that are associated to possibly understanding what is the mechanism. So there's one thing to say association, there's another thing to talk about causation. So it could be associated, but how is it influencing the phenotype? And so I'm going to show you something we've been able to do through collaboration with some of our other colleagues. And always, what I'm showing you here is that the SNP that we identified in the PASH1 apparently lies close to a gene, which is the PASH1 gene. And what you can see is that the SNP is non-coding. And this region where the SNP lie is actually an enhancer region. Now, an enhancer region refers to a region of the human genome that binds to the promoter of a gene to bring about expression or transcription of that gene. And so what it means is if there is a problem with that variant, it affects the ability of the enhancer to bind to the promoter, and that affects the transcription of the gene. And lastly, what I'm showing here is that the next question we ask is this gene even important in craniofacial development? And so I'm showing you here a single RNA-seq data, which shows that during the formation of the human face, this PASH1 gene is expressed in mesenchyme as well as ectodermal cells. And these are works that we are currently working on, and we should be publishing it out this year. So this is the era of GWAS. So with GWAS, what you are doing is you are just doing basically genotyping. And so the next thing that became common at the time was whole genome sequencing. And so in this whole genome sequencing, you are able to interrogate the whole genome. So this is not based on known SNP. So you can always interrogate the whole genome, and that way you can identify de novo variants, you can identify variants that have not been reported before. And so to do this, we actually leverage another collaboration. So this was a collaboration through the Gabriela Miller Kit Fest. And so we submitted part of the African sample, to be specific, 130 triad to this particular effort. And the question we are asking is, we know that most of orofacial cleft occurs sporadically. So I'm talking about the non-syndromic cases now. So most times you don't have, the parents are not affected, but you have the child being affected. And so it means that if they occur sporadically, then there must be a role for de novo variation. And so to answer that question, Wahid also led this particular effort where we asked the question, are there de novo variants in some of these kids that have orofacial cleft, but they were born to parents without orofacial cleft, that could be driving this phenotype? And when we did this, we identified several de novo variants in several genes that I'm showing you here. But because we know that orofacial cleft, especially the non-syndromic, is complex, just like Dr. Thirona mentioned earlier. So what it means is, instead of looking at single genes, single variants, can we start looking at a combination of those variants or a combination of those genes and start thinking about what processes are these driving? And to do that, we did a gene set enrichment analysis to ask the question, all these genes that have de novo variants associated with orofacial cleft, what processes are they involved in? And you can see here that the processes that are interesting to us are two of them here, neural crest cell migration, because we know the neural crest cell is important in the embryological development, or in terms of the embryology, when we talk about the formation of the face, as well as we can also see palate development. So this tells us that some of the genes that we identified are involved in these processes. And we know that these processes are important for facial clefts. And lastly, we also showed using mouse data, again, through another collaboration, that some of these genes are important in tissues that are present during the formation of the human, during the formation of the mouse face. So now, with whole genome sequencing also comes with a lot of other opportunities. So what do I mean by that? With whole genome sequencing, you get the whole, so in addition to being able to identify things that could be contributing to the cleft, you also get to see other risks that the patients might have that could be influencing other disease. And so this is what we call secondary finding. So the American College of Medical Genetics have a list of actionable genes. These are genes that have been said to be that have been said to be involved in diseases, and that if you know earlier, there is something that can be done to sort of mitigate the development of some of those diseases, like the BRCA1, the BRCA2 for breast cancer, and some other ones. And so what happens is, so through these administrative supplements, which was the grant that we used to support this particular project I'm going to be sharing next. And so the first one that I will be sharing was led by Abimbola. And so the question here was, this whole genome sequencing data that we have, apart from the genes that we think are contributing to the cleft, are there other variants in genes that could be actionable for this cohort? And so she found that there is about 23% of the variants in those actionable genes were actually likely pathogenic. And what is important, as you can see on this table, is that we found likely pathogenic or pathogenic genes in conditions, in genes that are associated with malignant hyperthermia. And this, again, would be important for patients that would be undergoing anesthesia before surgery, because knowing this would help the anesthetist plan effectively. And so the next question is, if we found this secondary finding, do patients want to know? That's one question about this finding, because this is not what brought them to the clinic, right, in the first place. The second thing is, are the providers confident enough to return this information? So we did a focus, we did a sort of questionnaire to ask this question, and to our surprise, majority of the patients want to know about this finding. 95% of them would like to really receive this information. But for the provider, we found out that about half of these providers also agreed that there is a need to return this finding to the patient. But majority of them, say over 75%, do not have any formal training when it comes to genetic education. And in fact, only 2% of them have been involved in delivering genetic information in the past. And so based on this was one of the problems we identified. And based on this, we've actually started some form of educational material to sort of improve the knowledge of these providers on genetic, delivering genetic information to patients. However, with the patient, one of the things that we also learned from the patient is, so we asked them, if you want to know this information, what would you do with this information? And a lot of them said, well, they would take it to the imam, to the pastors, to the community leaders in their community. And so based on that, we asked the second question, which is, these community gatekeepers, which are the imams, the pastors, do they even, I mean, what are they going to do with those information? Would they be able to support these patients effectively? And to do that, we did a focus group discussion to investigate three major concepts. One is the genetic knowledge, the belief, and the willingness to act. And these are some of the things we gathered from this information. So it shows that these community gatekeepers are willing to assist the patient, although in terms of belief, they still believe that, well, they've just wanted to know because knowing would help to pray against it. So, and this gives us a good opportunity for us to be able to intervene, to be able to give them the necessary information they need to assist these caregivers or these mothers that have patients with orofacial clefts. And so while we are doing this also, the next question that came up was, a mother already has a child with clefts, and then this mother is being told that there is a risk of maybe breast cancer or DM. You know, what is the impact of all this information on the mental health of these caregivers? And that was the next question we asked. And we had a focus group discussion to also tease out this. And these are some of the themes that came up during this focus group discussion. And one of it that I would want to point to us is the coping strategy. You would see that a lot of them say that one of the ways they were able to cope is to hold on to their faith and then the family support and then peer support at Cleft Clinic, which is another thing we found interesting, because it means that seeing other people that had some of these conditions and seeing how they cope can also help the patients in coping. And, you know, from this, the other thing that I would show is some of the statements from some of these mothers during this focus group discussion. Is one of them actually said she has never seen any, child with cleft until she has her own kid with cleft. Another one was talking about how this made her just to become an indoor person because she doesn't want people to see the child with orofacial cleft. And the third person did talk about, some of the myths that are associated with giving birth to a child with orofacial cleft, where people, attribute it to working at night or doing some things that, has nothing to do with why the child actually got cleft in the first place. And the last one that I would share is that because of what we have learned, now we're beginning to understand that there are ways that some of these mothers cope that we don't know in the clinic. And so can we use what they call photo voice, which is, asking them to take pictures at home, and then we can project those pictures and use those pictures to be able to narrate their experience. So we're trying to understand their coping mechanism, including their happy moments, which they necessarily might not be able to communicate, in the clinic without those pictures. And this is something that is currently ongoing. Now, I've told you about a lot of this work, but I will tell you that the challenges that we have faced with most of these projects is that currently most of these projects are still being test run in Nigeria. So we still need to be able to expand it across Africa, because we know that the settings would differ in terms of the community gatekeeper, in terms of the mental health or the challenges that the patients will face in the different aspect of, the different part of Africa. And I think one of the other issues that we've had is language barrier. So in some part of Africa, like the Francophone speaking, we've not been able to get collaborators that would assist with doing some of these projects in those regions. And the last and one, another important thing that we faced is in terms of funding. Most of these projects were funded by NIH. And so there is a need for us to have local funders so that we can start asking questions that are relevant to our own context or that are context specific. And to do that, we will need to have local funders in the region. And so just to summarize some of the things that I've shared here today is the development of the African Cleft Project and how the studies have moved from candidate gene to a multi-omics. So multi-omics involving genes, involving gene expression, as well as currently we are also involved in doing metabolomics studies. And how this has also helped in capacity building. So I've showed you several work, but these are works of different PhD students in the Italy lab, of which I was also part of that also. And our collaboration has allowed us to scale up recruitment. So we've been able to collaborate with individuals that work on mouse data, we've been able to collaborate with those that do a lot of transcriptomics data so that we can sort of get a comprehensive understanding of how these genes are causing these particular diseases. And lastly, we've also been able to follow the data. And then, so in terms of follow the data, because what we learned from the clinic is how we end up with community gatekeeper. And this is how we are also ending up in the community, trying to understand how patients cope, not just the patients, and how the caregivers also cope with having a child with orofacial cleft. And I think with this, I'm going to end by appreciating all the members that have contributed to this work. Dr. Thirona was also among those that contributed some of the projects that I shared here today. Thank you so much.
Thank you very much, Azeez, Dr. Alade, and please extend our thanks to Professor Butali as well for enabling you to share. And I think it was very insightful, because not only are you sharing scientific data, I mean genomic data, but you're bringing in the human aspect by speaking to the mothers and the community leaders to actually share their experience on having a child with an orofacial cleft. So I think that really humanizes it. So you were our final speaker for today, and as indicated by Louis on the chat, we are running rather behind. If you're willing to stick with us a little bit longer, we can finish up with some of those questions. If I can ask all of our speakers to actually go onto video, please, but just stay muted for now. Thank you so much to all our speakers for responding to questions on the Q&A to try and save some time. I know that Roslyn is busy typing away, responding to another one at the moment. There are another 2 questions that have come up on the chat. I'm just going to go for that last one from Lorna. And I'm not quite sure which issue you're talking about, Lorna. Perhaps it's the stigma. But you're talking about OFCs being of critical importance and representing a significant public health issue and directly influencing health outcomes and quality of life. To sustain momentum and enhance understanding, how can we continue this dialogue and further develop our knowledge base while also broadening access to timely, high quality and comprehensive interventions discussed by the various speakers? And also, is there a regional community of practice to which we can connect, ensuring these discussions and collaborations that they continue on a regular basis? So I think that's a great question for all the panel members. If I could start off and ask Professor Eshete to respond to that, please. How can we stop this from just being a webinar that just ends there? How can we take forward the specific issues that are so common across the different countries in the region and, you know, help make a difference for the child that was the patient that was highlighted in the Q&A? How can we increase the capacity of surgeons in Somalia and so on? If we could go to you first, Professor Eshete, and then we'll quickly go around the rest of the panel members. I'm not hearing Professor Eshete. Is everybody else hearing?
Sorry. Can you hear me now?
Yes, we can. Thank you.
Yeah, thank you very much. It is really an issue. The speaker from Somalia raised a question about having training. I think currently there are training possibilities. COSEXA, the College of Surgeons of East Central and Southern Africa, collaborating with SMATRAIN and Operation Smile, providing training for Africans. So maybe if he approaches one of these organizations through COSEXA, that may be a possibility for training. There is also a possibility to be enrolled in training, like at our university, people apply to the university and they get trained as a fellowship, or I don't know, I didn't know his background, if he's a surgeon or is a general practitioner. So there is a possibility now. We have trainees from Zambia, Tanzania currently. So that is one of the possibilities for the doctor. Any question you want me to address, Elena?
I think that's a good response on that one. Thank you, Professor Eshete. I just want to pass over to Roslyn. If you'd like to respond to that, how can we practically take this forward? And there's also a question in the text. It says you're writing an answer, but it's talking about speech formation and articulation. Is it influenced by the language? Say, for example, non-English, or are the speech difficulties the same across all languages? Just come off mute, Roslyn.
Yeah, sorry, my apologies. I'm certainly not the best person to address how to take this forward, you know, just having worked in my little niche of a nice tertiary hospital. But for me, I know, I mean, obviously training and getting more training is important, but maybe one can start more in communities of just sort of being a mythbuster, you know, just getting information out, just creating awareness about the cleft, that help can be sought, even if the help is minimal at this stage, you know, that this is not sort of a life sentence, not necessarily. For me, it's, I just think, you know, creating the awareness that these are, and maybe touching upon many of these, the stigmas, the cultural beliefs. I don't know if it's appropriate. You know, I'm not involved in these communities a lot, but I think just raising more awareness as a precursor, you know, while one is doing the training, etc.
I like that, Mythbusters.
Yeah, and sorry, the other question, I started typing and then I got a little bit confused, is, you know, speech is not quite the same as language. By speech, we talk about the motor processing, the actual speech that we make, and the sounds that we make. And of course, then we get the formation of words and sentences, which becomes language. And language is not just the output, but also understanding concepts. So, you know, it's slightly different. Yes, and what all I can say is that the sounds in different languages may well be different. For example, a glottal sound like a sort of a h is not common in English, but you get that sort of guttural sound in Arabic. You know, so yes, there are subtle differences, and one would have to be aware of the sound system in a particular language or in a particular sound system, but this doesn't necessarily mean that it's dictated by the language per se. So it's sounds versus a concept of output and input, you know, how you express yourself, grammar, syntax, and understanding the meaning of words. So it gets a little complicated there. Sorry.
Great. No, that's brilliant. Thank you so much, Roslyn. So,
just one point. Can I ask Dr. Roslyn?
Yes.
Is it easy for speech therapists to work with French speakers? Because there is some hypernasality in French.
Yeah, no, as I said, it's easy when we go in, you know, with Operation Smile. I always say to even my students, it's easy enough to deal with the hypernasality because you don't have to understand the meaning or how it's really about the quality. So I always say, if you're listening with your ear, even if someone's speaking Japanese, a lot of the time you'll know if most of the air is being emitted through the nose or not. So the resonance issue in dealing with velopharyngeal closure is quite easy to manage in another language. But it's the sound system. So I won't necessarily be able to teach articulation therapy. Most of the time one can, because there's so many similarities, and the kind of sounds that get affected are fairly common, you know, across the cleft population. So, you know, you could teach the placement, where to put the tongue. You know, many kids kind of use the back of the tongue and let air escape through their nose, what we call a pharyngeal snort. But in fact, an S is made with the tip of the tongue. So with an interpreter, it's really where to put the tongue and then build it up slowly. So it takes a lot of drill work. And often this becomes inappropriate, you know, in the developing countries, because, you know, they can't come to regular therapy. But we try our best. And in Ghana, we've often worked with a parent and at least given them some steps to start. Whether this will actually carry over fully, I'm not sure. But those are the challenges.
Thank you, Roslyn and Prof. Eshete. I'd just like to move on to another question now that's come in for Dr. Alade, asking, is it possible that this study can be replicated in other parts of Africa to add further information? And I'm sure you're going to say yes.
Yes, absolutely. Yeah, it can be replicated. I think that's why. So some of the studies that I shared, the pilot is in Nigeria, but we are all, I mean, we're currently working to do some of them in Ghana and I think in South Africa also. Again, those are some of the places where we already have established collaborators. I think the problem is, which is what I'll be asking from Dr. Butali also, saying that I should ask for potential collaborators to come on board to see if we could replicate in other African countries that are willing to do something similar. Because we think that this is not telling the full story, because we know how diverse Africa is. But yeah, this is just the ones that we already have people that are involved in, you know, cleft research, but we're willing to sort of expand to other countries that are willing to come up. We can always email. I can drop my email. You can email me or you can email them if they're interested.
Great. Thank you very much, Azeez. So the answer there is please connect with Azeez. And I just want to move on quickly because we are literally running out of time. I just want to move on to Thirona. And just building on the responses from Professor Eshete and Roslyn before, in, you know, how can we take this forward? And they have mentioned, you know, the role of collaboration and training outlined by Professor Eshete, and then, you know, potentially training with a non-profit organization, whether an international one or a national one. And then I like the mythbuster term that Roslyn came up with. Anything that you can add to that, Thirona?
So I just wanted to speak from our experience where we started with very little. We didn't even have a multidisciplinary cleft clinic. And it just takes one individual to drive that forward and get all the role players on board and get the medical manager on board. So if you start with that, that already improves the cleft care for the patient in your area. And then as Prof. Eshete and Roslyn mentioned, you know, you reach out to other role players. And with us, I found Prof. Butali, and that was because my research was going down the genomic route. But I also was introduced to Smile Train thereafter, and they were looking to fund researchers in Africa. So all of that, you know, sped our process up in terms of establishing our little cleft clinic. And I feel, you know, that's the way to do it.
Thanks, Thirona. You can do a lot with a room with some plastic table and chairs and the right people in the room. It's amazing what can get done. Thank you for that. Moving over to Kwaku, anything that you would add? So now we've added onto that list, we've added the role of champions and getting buy-in from hospital management and so on. What would you add, bringing that in from the Operation Smile focus in Ghana?
I think that, you know, the previous speakers have all talked about it, the importance of collaborating, because, for example, speech and language therapy, it's new, fairly new here in Ghana, and we need to just understand that we cannot do it alone. The comprehensive care is just huge. The need is so vast, and we have to work together on this. So much interested in Dr. Alade, your, you know, aspect that talks about community engagement, because it is something that they really need to understand. And it's important that they want to even know what causes some of these things, and it demystifies some of the misconceptions they have. And I cannot do it alone. Neither can Roslyn do it alone. We have to work together. There are certain parts of your presentation I was like, whoa. But then when it got to the community side of it, I could clearly understand it. And that means that we have to work together to make sure that the findings are clearly disseminated so that the community members clearly understand exactly what it is we want to achieve. And the community of practice mentioned was very great as well. We have to share ideas.
I think that's a great point, and it brings us right back to the SCAN network, which it provides that larger umbrella or that framework where this community can actually meet and continue to focus on this. And I think that as SCAN grows, that we'll potentially be having those substructures for the individual congenital anomalies, one of which would obviously be OFC. So thank you very much, everybody, and thank you to all our participants for joining. I've just asked us to go quickly round to any of the panelists that actually would like to say one more thing. I mean, you're allowed to have 30 seconds. So anybody that would like to just wrap up and say a final point from their perspective, and then we will be closing. So who's keen? I'm going to go to Roslyn because you said you had another thing to say.
No, it was one of the questions. Sorry, it was
Okay.
Not to respond to it. It was just a question about late repairs, and I just felt Dr. I'm not sure if Eshete is the name or the surname, would be in a better position to answer, because there does come a time where we feel it's a bit too late to repair the cleft palate. Certainly it is morbidity issues, I think, Prof, if you will comment in the older, and we're talking sort of the older teen, and for the palate is a problem because of bleeding, etc. But also the longer you wait, even 8, 9, the speech disturbances that have said become so habitual that it's hard to change. So I don't know if you wish to comment. There was a question about, is there a time that one cannot repair the palate?
Oh, yeah. I think I have responded on I've wrote the answer, but it's really a very good point. You know, there is a discussion. Early palate surgery is for better speech, but bad for facial growth. So people are trying to combine this to get a better speech and less impairment to the growth of the maxilla. So there is a Scandinavian study where they did soft palate and lip together at the age of 3 months and hard palate at the age of 3 or 4 years. The question is, I think, is a safety also is an issue. Cleft surgery has to be safe. No risk is accepted. So all the parameters needed to be fulfilled, like hemoglobin, weight, age, should be infectious-free. That's definite. No compromise on that. And now that everybody agrees that lip surgery is 3 months. There was a discussion to do even neonatal surgery. The argument was to reduce psychological pressure for the parents and for the children. But as I also said, cleft palate is not a one-time job. The patients are discharged from follow-up when they are 18 or 21. So for something which requires such a long follow-up, why take risk? Why do you do neonatal surgery taking a lot of risk? The other issue was that adult palate surgery didn't change anything. If someone reached to an adult age with cleft palate, there is already a compensatory mechanism for eating. They can eat properly without no problem. But some say that you don't change, you don't, Roslyn, you can comment, you don't change what is learned. Re-educating will be very difficult. But through hard work and speech surgery, I think other surgery will change the speech outcome. So that's it.
Great, thank you so much. That's a very interesting point there. And I think we've seen that patient, that 84-year-old patient, that it can still make a difference. So in some respects, it's never too late, but obviously the earlier the better, and the safer the better. So I would just like to say a huge thank you to everybody who's participated, and the faithful 54 that have stayed with us for this extra 20 minutes over the time limit. And thank you again to all our panelists for being willing to prepare and give up your time to share your expertise and knowledge with us this afternoon. We really appreciate it. There is a reminder on the chat that the recording of this webinar and the presentation materials will be shared on the sSCAN Knowledge Hub. So please go and check that out. And I'd also like to share that our next sSCAN webinar is coming up on the 25th of July, and it will be focusing on congenital infections, and that will be at 2 o'clock in the afternoon UTC +1, or in South Africa time, 3 o'clock in the afternoon. So please join in and register for that one again. And we look forward to seeing some of you back. And thank you once again for joining us. And we will be taking this forward and taking note of all these issues that have come up in the discussion. So thank you very much and have a great rest of the day. Goodbye.
Thank you very much. Bye-bye.
Thank you.
So much. Yeah,
Bye.
Thank you.